Welcome to Physician.Academy. Today we have an introduction to peripheral vascular disease. Please share our talks with others, encourage others to join us, like us on Facebook, subscribe to our YouTube page. As we grow and our community expands, we can offer more services such as test prep and, of course, better lectures. So today we have an introduction to peripheral vascular disease. We're going to talk about its etiologies, its signs and symptoms, diagnosis, and treatment. The etiology and the prevalence. Prevalence of peripheral vascular disease, also known as PAD, is about 12% in the United States. Risk factors. Some of those are for atherosclerosis. They're the same ones. Risk factors are the same as those for atherosclerosis. So if you have coronary artery disease, you'll probably have peripheral vascular disease, or vice versa. So it's increasing age are the common risk factors. Increasing age, hypertension, diabetes, dyslipidemia, low density lipoprotein, LDL cholesterol, or a high density lipoprotein, or in other words, a low HDL cholesterol. So a high LDL cholesterol or low HDL cholesterol. Cigarette smoking, including passive smoking or other forms of tobacco use. Family history of atherosclerosis, obesity, male sex, lucky me, and high homocysteine levels. 50 to 75% of patients with peripheral vascular disease, or PAD, also have clinically significant coronary artery disease, or CAD, or cerebral vascular disease. CAD may be present in part because PAD may prevent patients from exerting themselves enough to trigger angina. So what are the signs and symptoms of peripheral vascular disease? Its intermittent claudication is common, which is painful, aching, cramping, uncomfortable, or tired feeling in the legs that occurs during walking and is relieved by rest. Claudication occurs in the calves, but may occur in the feet, thighs, hips, buttocks, and it manifestation of exercise-induced reversible ischemia, similar to angina pectoris. As PAD progresses, the distance that can be walked without symptoms may decrease, and patients with severe PAD may experience pain during rest, reflecting irreversible ischemia. 20% of patients with PAD are asymptomatic, sometimes because they are not active enough to trigger leg ischemia. Atypical symptoms are examples of nonspecific exercise intolerance, hip or other joint pain. Mild PAD often causes no signs. Moderate to severe PAD commonly causes diminished or absent peripheral or popliteal tibialis posterior dorsalis pedis pulses. Those are a mouthful. Let me say those again. Moderate to severe PAD commonly causes diminished or absent peripheral pulses. So it would be the popliteal pulse might be diminished, tibialis posterior or dorsalis pedis pulses. Doppler ultrasound can often detect blood flow when pulses cannot be palpated. As ischemia worsens, ulcers may appear, typically on the toes or heel, occasionally on the leg or foot, especially after local trauma. Ulcers tend to be surrounded by black necrotic tissue, dry gangrene. Infection of ischemic ulcers, or wet gangrene, occurs readily causing rapidly progressive cellulitis. So let me say that again. That's a hard mouthful. And I wrote this. Infection of ischemic ulcers, or wet gangrene, occurs readily, causing rapid progressive cellulitis. Aortic iliac PAD may cause buttocks pain, thigh or calf claudication, hip pain, and in men, erectile dysfunction. In femoral popliteal PAD, claudication typically occurs in the calf. Pulses below the femoral artery are weak or absent. In PAD of more distal arteries, Femoral popliteal pulses may be present, but foot pulses are absent. Arterial occlusive diseases occasionally affects the arms, especially the left proximal subclavian artery, causing arm fatigue with exercise and occasional embolization to the hands. So how do you diagnose this? Diagnosis. Physical exam is really important. Brachial BP index, ultrasonography, and angiography before surgery. Spinal stenosis may also cause leg pain during walking, but can be distinguished from PAD because the pain, called pseudoclaudicalation, requires sitting, not just rest, to relieve the pain, and the distal pulses remain intact. So if you have a patient who says, they can walk so far, as long as they stop, the pain goes away. But if you have another patient that says, if I don't sit down, the pain doesn't go away, then there you go as how to differentiate the two. So what are your treatment options? So, of course, the first treatment option is to reduce your risk. So risk factors for modification are aggressive risk factor modifications, including smoking cessation, control of diabetes, dyslipidemia, hypertension, and homocystinemia, and dietary changes. So, of course, dietary changes can affect diabetes and dyslipidemia. Hypertension can be affected by exercise and by salt reduction. But of course, if we control these symptoms with medications as well, that'll decrease the risk factor. Exercise can increase symptom-free walking distance and improve quality of life. Let me repeat that. Exercise can increase symptom-free walking distance and improve quality of life. Medications, antiplatelet drugs are useful. Sometimes pentoxifylline or cilostazol for claudication. ACE inhibitors are another one. Where patients are advised to avoid cold and drugs that cause vasoconstriction. So antiplatelet drugs may modestly lessen symptoms and improve walking distance. So like aspirin, 81 milligrams to 162 milligrams daily. Clopidogrel or Plavix, 75 milligrams daily. And ticlopidine or Ticlid, 250 milligrams BID. Percutaneous transluminal intervention, or PTA, with or without stent insertion, is a primary non-surgical method for dilating vascular occlusion. Stents work best in large arteries with high flow. Iliac and renal are the good examples. They are less useful for smaller arteries and for long occlusions. PTA are similar to those for surgery. So the advantages of percutaneous transluminal interventions, or PTA, is similar to that for surgery. Intermittent claudication that inhibits daily activities, rest, and pain, and gangrene. Suitable lesions are flow limiting, short iliac stenosis, and short single or multiple stenosis of the superficial femoral popliteal segments. PTA is less useful for diffuse disease, long occlusions, and eccentric calcified plaques. Such lesions are particularly common in patients with diabetes, often affecting small arteries. Appropriate patient selection based on complete and adequate angiography is helpful. The initial success rate approaches 85 to 95% for iliac arteries and 50 to 70% for thigh and calf arteries. Recurrence rates are relatively high, 25 to 35% at less than 3 years. Repeat PTA may be successful. Surgery is the goal to relieve symptoms, heal ulcers, and avoid amputation. Thromboendarterectomy, surgical removal of an occlusive lesion, is used for short, localized lesions in the aorta, iliac, common femoral, and deep femoral arteries. Sympathectomy may be effective when a distal occlusion causes severe ischemic pain. So they can cut the nerves that's the sympathomectomy, may be effective. Amputation is a procedure of last resort. So yeah, of course, no one wants to lose a limb. It's indicated for uncontrolled infection, unrelenting rest pain, and progressive gangrene. Amputation should be as distal as possible, preserving the knee for optimal use with a prosthesis. Well, yeah, that's obvious. External compression therapy. That's another one that people are experimenting with. External pneumatic compression of the lower limb to increase distal blood flow is an option for limb salvage in patients who have severe PAD and are not candidates for surgery. This controls edema and improves arterial flow, venous return, and tissue oxygenation. But data supporting its use are lacking, so it's kind of last resort. It's your only last option. Pneumatic cuffs or stockings are placed on the lower leg and infiltrated rhythmically during diastole, systole, or part of both periods for 1 to 2 hours several times per week. As an alternative, the final thing that they're looking at is bone marrow stem cell transplantation. It's unknown, and the trials and new therapies are planned. So this concludes our discussion or introduction to peripheral vascular disease. Thank you for joining us today. Share our talks with others, encourage others to join us. Like us on Facebook, subscribe to our YouTube page, and remember, as we grow and as you help us grow and our community expands, we can offer more services like test prep and also much better people to do lectures. I'm trying to get out of this, so if we can get others to do it, that'd be great. Thanks for joining me.